Our next speaker is Dr. Stamou. He's going to kindly talk about prophylactic HIPEC and PPAC for colorectal cancer.
Okay, thank you very much. I feel most honored and privileged to be here and give this talk in front of both younger surgeons, but also in front of people that have shaped colorectal surgery over the past few decades. Now, we will talk about the concept of prophylactic or proactive HIPEC in cases of colorectal cancer. So, what exactly we're talking about is what exactly proactive HIPEC is an effort to alter the expected natural history of this disease. And the key word here is actually the expected, because we don't really know which of our patients will eventually develop peritoneal carcinomatosis. Now, in order to understand which of the patients, we need to identify certain risk factors. And I will shape this talk on certain questions, and these are: how often it occurs, is there a cure for peritoneal metastasis from colonic origin, can we predict it, and can we avoid it? And actually the answers are not very clear always, because how often it occurs anything between 5 to 45% in the course of the disease, depending on how you look for it. So if you look with second look surgery, then the percentages go higher, but if you look with CT scans, then you don't really realize when peritoneal carcinomatosis starts spreading into the abdomen. And is there a cure for it? Well, it seems that there is some cure for it. There seems to cytoreductive surgery with HIPEC provides option for cure, but only if the patient is treated at what is called the maximal low PCI, peritoneal cancer index, meaning that we have chances of curing these patients when we operate on them and they have minimal peritoneal disease, not when peritoneal disease has spread throughout the abdomen. And can we predict it? Well, maybe, but we lack absolute predictors. And can we avoid it? This is exactly where proactive HIPEC comes into this game. Now, if we go back, the first and most obvious reason why some patient will be discovered with peritoneal carcinomatosis is because he has a very large T stage, a T4 stage, meaning that cancer cells have exfoliated into the abdomen and have spread. Now, the rest of the procedure is unknown, why these cells actually interact with the stroma, why do they adhere there, how do they migrate. We don't really know about that. But the obvious thing is that you get spontaneous peritoneal carcinomatosis when cancer cells drop from the surface of the bowel into the abdomen. And this has been actually proved in a very large registry, Swedish registry. Some of the people that produced this paper are here in this room, where the T4 status actually increased the possibility of peritoneal carcinomatosis in the course of this cancer tenfold. So a T4 is a pretty high risk patient, and maybe we should focus on these patients to understand whether we should give them HIPEC or not. Now, the same authors provided a tool, a mathematical tool, and T stage is still a very important factor in determining which of the patient is in risk. Now, this comes after surgery. What about before surgery? The ideal would be if we knew beforehand if our patient actually has a T4 tumor, because then we could probably plan HIPEC during primary surgery. Now, is this possible? It is if you have very good radiologists and very well-trained radiologists that can actually distinguish with millimeters whether a tumor has gone through the muscularis propria and towards the serosa and into the abdominal cavity. And it has happened in the past by very good radiologists, where to understand the slide, whatever is red means that the radiologist actually predicted correctly that the T4 tumor was either a T4 tumor or an advanced T3 tumor. And they did that correctly in 62 out of 67 CT scans. So we could identify real T4 dangerous high-risk patients before. And there is an ongoing, two actually, randomized trials where T4 patients either get HIPEC or not during primary surgery in order to understand if that reduces the possibility of peritoneal carcinomatosis. But of course, somebody goes there first, and it's the oncologist who did that, because they know much better how to dance these dances, the foxtrot. So if you give neoadjuvant chemotherapy to these patients, it has been shown, these are the pathology results from the foxtrot trial, you get a shrinkage. So you get less T4 patients. So my impression is that in the future, whenever you have a T4 patient, it will not be an option whether you will give him HIPEC or not. It will be a patient who will have neoadjuvant chemotherapy. So this high-risk indication, the T4 patient, comes out of the game, well, maybe, for the HIPEC, because they will all get neoadjuvant chemotherapy. And the question is whether we would be able to add HIPEC into the therapeutic scheme of these patients. And of course there's an elephant in the room, which we do not really see, and that is the molecular biology of the tumor. Because we know that if you have a BRAF wild type, the prognosis is very bad, but also you get approximately double the possibility of getting peritoneal carcinomatosis. And we don't really know how to interpret this in terms of whether you will do HIPEC or not. This means that there are two ways of thinking. So these patients are very bad patients, they have a very bad cancer, so we better give them anything we have, both HIPEC and systemic chemotherapy. But there's another way of thinking, that these patients will not do well whatever we do for them, so avoid extra treatments that are not justified. So we have no idea, and we have not put into consideration what to do with the molecular identity of the patient. So focusing on much more clinical risk factors, Paul Sugar-Baker, who's of course one of the most intelligent and actually one of the surgeons that knows what he's doing and understands what he has seen in his experience, provided some clinical indicators quite early, this is 1999. And he focused on major events like having minimal peritoneal metastasis at primary surgery, or having a perforated tumor, or having deposits on the ovaries. So these seem to be the most important risk factors. And this was actually true in this collective work by Honoré, where throughout the literature it seems that whenever you have even minimal peritoneal deposits in the primary surgery, or a perforated tumor, that's when you get peritoneal carcinomatosis in the future. So these are the patients that could be see some good from HIPEC, proactive HIPEC. Now with Professor Xinos and Nikos Gouvas and George Peklivanides, we conducted this review, and of all the papers on HIPEC, actually there are only 12 on prophylactic HIPEC, and we managed to clear out 4 different ways of administering HIPEC in the prophylactic setting. And this is HIPEC during primary surgery, and this has a difficult logistic problem to solve because HIPEC is not readily available, apart from some centers that do cytoreductive surgery. So in the primary setting, in the primary surgery for colorectal cancer, very few hospitals in the world actually do HIPEC. The other way is doing EPIC, which is early postoperative intraperitoneal chemotherapy after primary surgery, early laparoscopy with HIPEC, and second look laparotomy. And to go through this, so we have HIPEC during primary surgery. There are 5 studies have shown a very, very low percentage of peritoneal carcinomatosis in the follow-up. Now the problem is that all these numbers don't come after second look surgery, but they come after CT scans and the regular follow-up of the patients. So this might be a bit higher. And also the pretty different definitions of the high-risk patients, different choices for chemotherapy during HIPEC, and different type of surgery, because some of these surgeons actually did some sort of cytoreduction in the primary setting. And one of the problems, and I think Dr. Rao addressed that earlier, is that we don't really know what to give and how much to give. In most centers, we give mitomycin C, and look at that, we have from Washington basic stock to Holland, you have completely different regimes, so we don't really have standardized the HIPEC treatment, even in the most simple cases, and this needs to change. Also, those studies compared adjuvant systemic chemotherapy to HIPEC in order to reduce the incidence of peritoneal carcinomatosis, but this seems to be somehow irrelevant because all these patients will have systemic chemotherapy. So it's not a question of whether they will have one or the other, it's a question if you can integrate HIPEC into the general scheme of this patient's treatment. Now, EPIC after primary surgery Sugarbaker did that originally, way back when he was working at the NIH, and actually he failed to show any real difference in oncological outcomes by adding EPIC to the primary surgery, but there could be some less peritoneal metastasis. These are difficult to interpret studies because these are old studies, they are randomized, but we have very different definitions of what is a peritoneal spread at the time and what drug to give. So EPIC has been somehow abandoned, also because it has a very high morbidity rate after surgery. This is an interesting concept. What about after we operate on a patient and we know that this is a high-risk patient because we have a histology, why not do an early laparoscopy and then HIPEC? There are two studies of that. Not conclusive, a very low incidence of peritoneal carcinomatosis. I repeat, this should have been anything between 30 to 60% if these patients were real high-risk patients, but it's only 5 or 0%. But of course, this is a short follow-up period, and also these patients did not have second look surgery. They had CT scans. We don't know what happened to these patients after the 2 years. And also, the patients that have laparoscopy at 3 to 6 weeks are delayed into having systemic chemotherapy, so this may not be wise. So, it comes back, second look surgery. It started many decades ago by Wagenstein, who said that the best way to understand if this patient has peritoneal metastasis and to treat that is by multiple second and third look surgeries. He did that, only he had a 7% mortality rate, which was probably accepted at the time, but not today. But the most important study that deals with prophylactic HIPEC comes from France, is the work of Dominique Elias from the Stamou C Institute. So in his original paper in 2008, he split patients. He had high-risk patients, and he gave them FOLFOX for 6 months, and then operated on them in 12 months, regardless of whether on CT scan there was any evidence of peritoneal disease. And what he found out is that half of them actually did have peritoneal disease. And if he give HIPEC and cytoreductive surgery to these 16 patients, these patients did fairly well. But the most interesting fact is what happened to the patients that did not get HIPEC because they did not have peritoneal disease at 12 months or did not have peritoneal disease in the first place. These patients did not do very well. They actually did worse than the rest of the groups. And that is because obviously these patients had microscopic residual disease in the peritoneum. They did not have HIPEC, and so they recurred afterwards. So according to Elias, this second look strategy, which is dangerous, has drawbacks for the patient and for the health system, should be proposed exclusively in selected patients. And this is exactly what we need to do, because Dominique Elias managed to distinguish what exactly constitutes a high-risk patient. That is, the patient who had a minimal peritoneal carcinomatosis in the original surgery, the patient who had ovarian deposits, or the patient who had a clearly perforated tumor. And the French are running this randomized trial now, the Profilo CIP. CIP is HIPEC in French, where the high-risk patients get 6 months of FOLFOX, and then with a negative workup, they either go with surveillance or have laparotomy and HIPEC. And we're really forward looking for the results of this work. Now, in conclusion, efforts should focus on the identification of high-risk patients, and this is better radiomics and a real molecular profile of the patient, and start thinking of HIPEC as an adjuvant into this whole therapeutic scheme of the patient, and not something different that one surgeon will do at some time in the course of this patient's treatment. And HIPEC should be made easily available outside the context and the concept of carcinomatosis. If you have 1 or 2 hospitals in every country that actually do HIPEC, it's not easy to work forward. But if you have the possibility of doing HIPEC outside the cytoreductive scheme, then HIPEC would be more easily available, and then probably find the proper indications. And the goal for all this is to treat at maximal low PCI by using proactive second look surgery plus HIPEC. This is a very interesting concept, and probably the only one that has been somehow cleared in the literature. Thank you.
Any questions? I think we've got a couple of questions here. Can you read it from there?
Okay.
Sigmoid T4 tumours with tumour nodules in the peritoneal vicinity is proactive HIPEC recommended.
According to what we know, ideally you should do it at the same time, provided that the patient is well prepared, anesthetically and in general. If you have the machine, if you have the circulator and HIPEC is there readily available, and if you have the ICU ready. So ideally you can do it, but that means that you have already studied your patient pretty well and you've done all your workup and you've done your homework and you're ready for it. If you do not do it, then you refer the patient probably so that he can have a second look surgery in a year's time after 6 months of follow-ups. That's what we know so far.
Okay.
Yes.
Question?
This is for
Right.
Dr. Rao.
Yes. Well, that's an interesting question. Actually, that was the first paper I published when I was in Washington. Whenever we were doing subtotal colectomy at the time, there was no anastomosis. Actually, there was an endarterectomy most of the times. Now, that depends on the length of the operation and how well he can tolerate a possible leak, and on the prognosis. If this is a CC0 resection, then and everything has gone according to plan, then most probably I would do an ileorectal anastomosis. I consider that a quite safe anastomosis. But if I have worries about whether this patient will recur very early, then I would definitely do an ileostomy. I don't know what is your preference.
Yeah, for patients with where I do a colectomy, I think usually this is not a high-grade cancer. Usually it is more a mucinous type of cancer.
Okay.
So these patients have a better prognosis. And if it is possible, I always do anastomosis without stoma.
Good. I agree.
Thank
you very much.
Thank you. All right, so I think without further ado, we'll move to the last